Good morning. Good morning. Good to have you. And today we are going to do the mixed case studies. And this is going to be super important for you to remember because you might be getting case studies like the unfolding case studies, which we have been talking about. So like one case and there is going to be 6 steps. So 6 questions from one case study and you will be getting a minimum of 3 of them. Now, inside that, usually those unfolding case studies will be focusing on just one patient. However, you might also get unfolding case study, which means just one case study, but in that case study itself, there is multiple clients. So it's more like practicals. It's more like you go to a hospital and you will get more than one patient, right? You might end up getting 3 patients, 4 patients. So how are you going to manage those 4 patients over the period of your shift? That's how it's going to be. So we are going to do something like that today. It's going to be a lot important and essential for you to remember how to manage these clients, how to look for each step, and what exactly NCLEX is trying to ask you in each of these steps. Okay, so we will go through each of them. A nurse has been assigned the following clients for the shift. So there are 4 patients and we are going to say client A, client B, client C, client D. But in the actual exam, you may have other names in it. You may have tabs where you have to keep, like clicking on those tabs to open more information. Okay, so make sure that you are doing that. So client A, a 72-year-old client with a known history of chronic heart failure, was admitted overnight for worsening shortness of breath. The client states, I couldn't sleep at all because I felt like I was suffocating when I lay flat. The client is sitting upright in bed. Client B, a 68-year-old client who presents with complaints of palpitations over the past week. The client states, sometimes my heart feels like racing and skipping beats. The client denies chest pain but reports occasional shortness of breath with activity. Client C, a 45-year-old client who is hospitalized with fever, chills, and persistent fatigue for past 2 weeks. The client reports night sweats and decreased appetite. The client has a history of intravenous drug abuse and was recently treated for a skin infection. And lastly, client 4, a 76-year-old client who arrives on the unit after experiencing dizziness and 2 near syncope episodes at home. The client reports, I'm very tired for the past few days and also feel like I'm going to pass out when I stand up. So we have 4 clients with 4 different situations, and this is all we have right now for our first case study question. And the first case study question is going to be focusing on recognizing cues. Okay, it's all about, are you able to figure out what's going on? What is the most important thing we should be dealing with? What is something I can probably keep aside? What is something which is going to tell me that this is not okay? I need to recognize this so that I can prevent the patient from going into complication. That is always going to be your first case study question. It is going to be about your ability to recognize the cues. Okay, let's look at the question. Okay, so the first question is, which finding should the nurse recognize as the most clinically significant cues indicating potential deterioration? Now, there's a lot of words in there. What exactly is it asking? Or in simple terms, what is this question really asking me? Out of these 4 things listed here about 4 clients, which one is going to be something I should really be recognizing early? Okay, it is important for me as a competent nurse to see that because I know this is going bad. Okay, that's what we are looking for. Now, all the answers here might seem like something very important. And of course, all these patients are admitted with some kind of problem. So there is going to be issues. The best way we can deal with this kind of question is using the strategy of elimination. So figure out which one can we eliminate. Do not jump into the answers. Do not go through it like don't make any silly mistakes. Go through each one and see which one can be eliminated. Okay, so number one, client A reports inability to lie flat due to shortness of breath. Now, what is the name for that issue? Now, our patient has that problem. What is that term which we use for that? It's called orthopnea, right? When they cannot lie flat, they have to be like sitting up or in a recliner position. That's orthopnea. Now, is that possible with this patient? The patient is already saying, I have that problem. But what is the diagnosis? The patient is already known for a chronic heart failure. Okay, so a chronic heart failure patient having orthopnea, is that expected? Is that going to be itself a very important problem where there is potentially declining? Because I see that some of you might think that is the answer, but it is not. Because this is orthopnea which can be present in heart failure patients, especially when there is, they are not taking care of their heart failure or they are not, maybe like exacerbation of heart failure, right? So that's the one I am going to probably eliminate. Okay, let's look at number 2. Client B reports occasional shortness of breath with activity. Occasional shortness of breath itself is something I'm like, it's bad. Okay, I don't know what's going on with this patient because he says he has complaints of palpitations over the past week. So something is going on, and the patient says sometimes my heart feels like it's racing and skipping beats. So I am kind of concerned. I know there could be some cardiac problem here, but there is no chest pain, which is a great thing, and occasional shortness of breath with activity. So my question is asking, which is the most clinically significant cue indicating potential deterioration? Now, what is meant by potential deterioration? They are going down fast. If I don't do something, they are going down fast. What is that? Now, when it says occasional shortness of breath and just with activity, which means when they are just resting, they don't have that much problem, probably, right? Is that going to be an important thing for me? I would say probably not. Okay, I'm trying to help you to eliminate. So this is eliminated, this is eliminated. Now I'm going to go with the third one. It's client C who has an intravenous drug use and reports night sweats and decreased appetite. I have no idea what's going on, but I am thinking about, with the substance abuse problem, something is going on, maybe an infection. I have to figure it out, but it doesn't look like indicating potential deterioration like faster. Like it's night sweats and decreased appetite. These two things can be like anything, right? It can be tuberculosis, it can be cancer, it can be some infection, it can be sepsis, it can be a side effect of the medicine or the drug abuse, or it can be anything like a complication because of the drug abuse. I mean, I have no idea. I still need more information, but seems like not the biggest problem at this time. I will keep it, right? And I will look at D. And this says client D reports very tired, dizziness, and near syncope episode, which means they are like, and the patient is like, when they're getting up, they said that I feel like I'm falling when I get up. Very tired, dizzy, near syncope episode. That is going to be something I will be more worried about. Out of 4 of these options, this client is going to be my main concern because this one seems like going down fast, very tired, dizzy, and almost fainting. Okay, the moment they get up, they are fainting. So I am thinking about, something about the cardiac output. I am thinking about this is not okay, right? So out of these 4, client D is going to be the most significant cue indicating potential deterioration, not the other 3. Now, please remember, we are not saying client 1, 2, 3 are okay. They are not okay. We know they are not okay. But in this context, with the information which is given to us, right, with all the other contexts which we can think about, this client seems to be the worst right now. Okay, and that's why they're having this tiredness and dizziness and syncopial episode, like they are like going down. Okay, that's not okay. Okay, I hope that is clear. If you have written the exam before and you have received, I mean, of course, if you failed the exam before, and if you have ever received a CPR, which is a candidate performance report, you will see at the end, there's a lot of things which they say above passing standard, near passing standard. You will see towards the end of that candidate performance report, there is a section which says clinical judgment. Look at that. Okay, get your CPR out. If you are a repeater, get your CPR out from the last exams and see where you stand in that clinical judgment area. And the first thing under that clinical judgment, you will see recognize cues. Those are your case studies. It tells you how did you perform in your case studies in your last exam. And the first one is this, recognizing cues. Now in that, if you are below passing standard or near passing standard, you have to work on it. You have to get better at getting these case studies, because no matter how good you perform in all the other questions, the case studies, if you didn't do good, you are not passing this exam. Okay, so it's super important that you're really good with that. We are going to the next step 2 of this unfolding case study, and all case studies follow this exact thing. Okay, so the second one is analyze cues, and when we say analyze cues, this is more like how do we put them together. Now that we have some information about all these patients, now it's time to put them together and see where it is, what is going on. So the question is going to be based on, are you able to connect it? Are you able to put those signs and symptoms in the focus of the question and understand what's going on? Are you able to figure out the possible disease condition, the possible diagnosis, the possible issue with this patient? That's what analyzing Q is all about. You're analyzing what you got. This is where you might get more information. Okay, so it says, during the initial head-to-toe assessment at the start of the shift, the nurse gathers the following information on each client. Remember, we started by getting these patients, and now the nurse is doing the assessments and she has more information. Okay, so in your actual exam, this is where you have to click on those tabs because they may have more information there. So here, this is what you know. Again, it's a lot of information. I have made it into a way that it is delimited for you, like to just get the information. But in the actual exam, you may have more things there. You may have a lot of lab studies. You may get more diagnostic studies and results. So be prepared for that. Be prepared to read a lot, think a lot, okay, in your exam. Okay, client A, this is what we know now. Respiratory rate is 26, oxygen saturation is 92 in room air, lung auscultation reveals bilateral fine crackles. Now remember, client A is our chronic heart failure patient. Okay, history of chronic heart failure patient. That is the client A. Okay, so their respiratory rate is a little high, but the saturation looks okay. There are crackles. It's a CHF patient. Client has +2 or 2+ pitting edema in lower extremities and reports 3-pound weight gain over past 3 days. So putting all those together, you have an idea. Okay, this is a heart failure patient who is probably not doing the right thing. So whatever reason, it is getting more fluid accumulated, right? So that's why there is crackles, there is edema, there is weight gain, all those signs and symptoms which is kind of contributing towards that. Blood pressure is 158/88 and heart rate is 104. So a typical CHF exacerbation patient who is admitted, right? Second one, client B. Apical pulse is irregularly regular at 96 beats per minute. All right. The radial pulse is weaker and inconsistent compared to the apical pulse. Blood pressure is 136/78. The client appears tired but is alert and oriented. The electrocardiogram monitor shows no distinct P waves and an irregular ventricular rhythm. All right. This is where we put our knowledge and our information and our thinking process together to figure out what's going on with this patient. Now, if you remember, let's go back to the first part which we had. This was a 68-year-old client who came with palpitations and sometimes feels like my heart is skipping beats. No chest pain, but shortness of breath, occasional shortness of breath with activity. So this is the client we are talking about. Now we have more information. We have the vital signs and we have the ECG. Okay, but in this question, they are not giving you the ECG tracing. We have to figure out from this, it is 96 beats, it's irregular, and there is no distinct P wave, and it's an irregular ventricular rhythm. So we have to figure out what's going on. Okay, the third patient, so this one who was having decreased appetite and night sweats. So this one says his temperature, okay, he is having fever. It's 101.8. Cardiac auscultation reveals new systolic murmur, which was not there. The client has small tender lesions on the fingertips and reports joint aches. Okay, so IV drug use, had some kind of infection before because it says he was recently treated for a skin infection. He was having fever and chills. Well, obviously right now also he has fever and he has persistent fatigue over the past 2 weeks, night sweats, decreased appetite, and what else do we know now? He has small tender lesions on the fingertips, joint aches, and he has a new systolic murmur. Okay, so client D. This is the one who had that near syncope episode, and we think that is a really bad problem going on. We don't know what it is, but we think there is something going on. So this heart rate is 38. No wonder he was feeling, kind of dizzy and tired and was feeling like he's going to pass out when we get up because his heart rate is really low and it is irregular. Blood pressure, look at the blood pressure, 88/54. Okay, now severe hypotension, and we see the heart rate here, and client appears pale and diaphoretic, sweating. Okay, not good, right? Oxygen saturation is 90. Telemetry shows, okay, now again, we don't have the ECG with us, but they have explained to us in words how the ECG looks like, okay, the interpretation. It says it's regular P wave with fixed PR intervals and dropped QRS complexes. The client is slow to respond but remain oriented, and the capillary refill is delayed. Okay, it's not good to have a delayed capillary refill, right? That means there is some kind of issues with the circulation. All right, so look at these patients, thinking through them, making connections, trying to figure out what exactly is going on with all these patients, because analyzing cues is all that. And that's the step 2 in our unfolding case study. The second question in your unfolding case study will be analyzing cues. All right, promise you that. Okay, so this is what we need to figure out now. This can come as a drag and drop. This can come as a drop down clause. So all you have to do here is, what is client A having? What is client B having? What is client C is having? What is client D is having? You can use only one for each patient. Okay. We have 10 options here. And do we have to know all about all these disease conditions to answer this? Answer is yes. Is just the theory going to be enough? No, because we have to put them together in the context. So let's focus on just one at a time. Client A. Out of all these problems, if you can select only one thing, what is client A is having? We know it's a CHF patient. We know it's an exacerbation. We know there is crackers. We know there is edema. We know there is weight gain, 3-pound weight gain. We know that he has tachycardia and and hypertension. Yes, what is the best thing out of here which I can think about? That's going to be the fifth one. I would say client A is having fluid overload, right? That's the best option for that patient because we have all the information to tell us that this is a CHF exacerbation. So instead of fluid overload, if it was CHF exacerbation, I would have gone for that. If it said something about, acute heart failure going on, I would have selected that. So as of now, what is going to be the best fit from the options is going to be fluid overload. Now let's focus on the second one. What about client B? Now, who was our client B? Client B was the one who was having skipping beats or occasionally feeling short of breath with the activity. And we did have an ECG. And ECG says no distinct P wave. So the moment I see that there is no distinct P wave, I know how the P wave is supposed to be in the ECG, right? I know it's like supposed to be like P wave, and then we have a little Q, and then R, and then S, and then we are supposed to have a T, So this P wave is not there. We don't have any distinct P wave. So if there is no P wave, if the ECG, the P is like that, that is AFib. Now, can somebody with AFib have 96 beats per minute? And the answer is yes. Now, how do we know it's irregular? There is another point here which they have suggested to us to let us know it's irregular. It says irregular beats, and this is radial pulse. Okay, when I said the radial pulse, it's weaker and inconsistent compared to the apical rate. Now, the apical rate, we know we have to use the stethoscope and we put it in the mitral area and we listen to the heartbeats. So that's how we get the apical heart rate, like for 1 minute. But whenever I am taking the radial pulse rate, because it is irregular, I'm not getting everything here. Okay, so this is where we know it's an AFib. So what's going to be the best option for client B now? Client B, I would say this one is, where is it? Okay, atrial fibrillation. Okay, so client B is possibly having atrial fibrillation. All right, let's go to client C. Let's see what can happen to a patient who is IV drug abuse patient, and we know there is an infection, there is an infection. How do we know that? Because he is having fever, he is having sweating, he is having decreased appetite. So we know it's an infection. So I don't think it's iron deficiency anemia. Now, I'm thinking about valvular heart disease, maybe. I'm thinking about rheumatoid arthritis because he said there is joint pain and stuff. And yes, I'm thinking about infective endocarditis. I don't think it's pericardial effusion, because if it is pericardial effusion, he will have chest pain and he will have a lot of shortness of breath, which was not there, right? So I don't think it's that. We already took out fluid overload. We already took out atrial fibrillation, and it's not sinus bradycardia. We know the heart rate and stuff, right? So it's more like towards this. So let's see. There are a couple of things which are very, very specific here towards infective carditis. Okay, fever is one, but fever can be also in other things. Yes, new murmur. It says there is a new systolic murmur. Okay, that's one. Now, when there is a new murmur, I think I can avoid rheumatoid arthritis and more towards valvular heart disease or infective endocarditis. In those two cases, we can still have a new murmur. So now I am between, like, is it valvular heart disease or is it infective endocarditis? But valvular heart disease may not have fever all the time. But this guy has fever. So I'm still going towards infective endocarditis. Also, there are tender lesions on the fingertip. That is very, very important to remember. Now, we talked about it in cardiac lesson. In endocarditis, we talked about it. Patients will have fever, there can be new heart murmur, and there can be painful nodes, right? And we talked about all these oscillus nodes and these issues which are very, very specific to endocarditis. We discussed this in cardiac, okay? So in case you are not familiar with this, once you get into the cardiac lesson, you will learn all about this, I promise. Okay, so that's where we are kind of, it says painful nodes. And when they say it's like tender lesions, tenderness means painful. So when you touch, it's painful. So we have all the data now to say that this is infective endocarditis. Now the next one, the client D. The heart rate is 38, blood pressure is 88/54. Client is really not stable, hemodynamically not that stable, appears pale, diaphoretic. Okay, there is an ECG. What is this ECG? P wave is regular. PR interval is fixed. But there is dropped QRS complexes. Okay, this is heart block. Okay, this is second degree type 2, morbid 2. There are regular P waves, PR intervals are the same, but there is dropped QRS. Okay, and because of that dropped QRS, that's why their heart rate is so low, right? It was 38. And he is not hemodynamically stable. He's 88/54, severe hypotension, symptomatic, right? This is really bad. And capillary refill is delayed. This is decreased cardiac output, conduction delay, not good. Now, this is not sinus bradycardia. I know there is a sinus bradycardia here. This is not sinus bradycardia. Don't go for that just because the heart rate is 38, because we know there is dropped QRS. In sinus bradycardia, there is no dropped QRS. It's just everything will be there, but it's just slow, right? But this is not that. This is more problematic than that. So, what is going to be our answers in this one? Okay. Okay, now we are on the third step of this unfolding case study. This is where prioritization comes. We'll have to figure out which client is a priority. And I think this is going to be easy for you to figure out. Which one would you say is a priority at this time? Who is hemodynamically unstable at this moment? And yes, that's going to be our patient who has, blood pressure is 88/54, heart rate is 38, is pale, is diaphoretic, is like barely having 90% in room air, and is having second degree AV block type 2. This guy is going to be our priority. Okay, very good. I'm sure that you all identified it with our discussion. We are going to move forward to step 4 of the unfolding case study, which means the fourth question you are going to see in your unfolding case study is about planning. It's about generating solutions. Now you are thinking, now you know what are the problems going on. You have a possible diagnosis right now in your mind with all the clients. Now you are thinking, as a competent nurse, what is something I might be doing? What should I anticipate? What is probably the plan of care for these clients? What can we do in the future to get these things corrected? Okay, that's the question is. So here is what is going on. Which planned interventions are appropriate for each client based on the findings? And just one per client, okay? One thing per client. This also can be a drag and drop. It can be drop down. So either way, just figure out what is going to be one thing you can do. What would you say? Our CHF client, right? Now we can probably name each client. This is our CHF client. What would you do? One thing I know for sure, I am not going to give IV fluids, right? He's already fluid overloaded. No. So what is the best thing I can do? Loop diuretics. Yes, we need to get that fluid out. So one thing I will do for this CHF patient who is overload is initiate loop diuretics. Very good, very good. Because diuretics are going to help with releasing those extra fluid. How about client B? This is our AFib client, atrial fibrillation client. What is something we can do specific, okay? Be specific. The client with AFib, what is something we will be giving to them? It's for AFib client, we will be administering anticoagulants. Now, when we talked about the ECTs and the AFib, one thing we discussed, is that atrial fibrillation, patients can go into thromboembolic events. There can be clot formations inside the heart because, it's not really compressing, it is just fibrillating. So we have to prevent that, right? So the patients will be on anticoagulants. There could be all the other medications too, okay? I mean, anticoagulants are not to treat AFib. Anticoagulants are to prevent complications which can come from AFib. To treat AFib, we may have to give other medications, but none of them are listed here. So from the available option, the only best thing which we can kind of go with is going to be anticoagulants. Yeah, and we know this AFib was not unstable. It was not high rate. It was 96, and the patient didn't have any chest pain and occasional shortness of breath with activity. So we may not be doing a lot of procedures on this patient because this patient is hemodynamically stable. Okay, so we will try to treat this AFib with medications. And then if that fails and if the patient comes back with, or something else is going to happen with more problems, then we might think about like cardioversions or something like that. But that's not going to be the first. Okay. So coming to C, client C, this is our endocarditis patient. What do we do with endocarditis? Okay, we give antibiotics. Very good. This patient is going to get IV antibiotics. Now, is that patient going to get IV fluid? Maybe IV fluid bolus? I don't know, because I don't think there was dehydrations, and it can happen with fever and sweating and stuff like that. But between IV bolus and IV antibiotics for a patient with infective endocarditis, if I can choose only one, I will go with antibiotics because that's more important. Okay, so that's why we are going to go with 2. All right, client D, this is the one with AV block. Okay, what do? We need pacemaker placement. Okay, did somebody say atropine? I mean, atropine is something we use when there is bradycardia, right? I mean, in AV block also in some cases, atropine is one of the way to go. But if you look at our cardiac lecture, we have discussed this. When there is already morbid type 2 and hemodynamically unstable, atropine is not going to be the best choice. Okay? Because atropine may make it worse and the patient may go into asystole because it's already like really bad. So the best option for this patient is going to be, we need a pacemaker for this patient. Okay, and that's why I'm not selecting atropine. I'm going to go with prepare pacemaker placement. Now, for the other cases, if it was just a sinus bradycardia or even symptomatic sinus bradycardia, I would have gone for atropine, because atropine is like, when you think about the ACLS pathway, that's how we manage it. But this is not just any symptomatic bradycardia. It's a type 2 morbids too, right? So, all right. So, are we okay so far? Right? This is going to be the way we are going to generate solutions in our fourth area. Okay. Now, like I said, if you are a repeater, go back to your CPR and see where you are near or below passing standard. You have to be above passing standard in all these steps. Okay? Not even one can go down. Step 5, taking action. This is where the actual implementation will come. Like exactly what we are going to do, what are we doing, okay? So in this question, look for things which are specific action to the client, specific action to the context which is discussed. Such as taking actions. Now it says in that, sometimes I said that there will be like those tabs where you have to press and you get more information. So new assessment data and findings are available for the clients now. So that's when you will click on those tabs and see more. So this is what it says. Again, a lot of more information, new information about the patients, right? Number one, the CHF client, the client with chronic heart failure becomes here is a problem. Acutely restless and anxious. Respiratory rate increases to 34. Oxygen saturation drops to 84 despite having nasal cannula, 4 liters nasal cannula still down. The client begins coughing, frothy, pink sputum. Lung sounds reveal coarse crackers throughout the lung fields. Blood pressure is now elevated more, 176/96, and heart rate is 118. Let's focus on this. What do you think is going on with this patient? This is pulmonary edema. Yes, true. This is pulmonary edema, which is not expected, not okay. Now, I said weight gain and little bit of weight gain, maybe shortness of breath with activity, and not able to sleep, lying down. Okay, those kind of things are probably, I can still see it happening with a chronic heart failure patient. But this is complication. In one set, this is hypoxia. Client B, the client with palpitations, this is the AFib client. Okay, this is what is going on with him now. Slurred speech, facial drooping, right-sided arm weakness. Okay, we knew that there is a chance of that thrombus, so there is a blood clot which formed and it did travel to the brain, and now the patient is having a stroke. Just like how I said that my dad with AFib ended up having a stroke, right? We discussed that in our class. So just like that, atrial fibrillation can cause a lot of thromboembolic events. Okay, blood sugar is 112 and telemetry show AFib with what, now it's kind of getting bad. And the patient was seen last time, like all okay in 45 minutes ago. This is important. That timing is important because we know in stroke patients, we may have to give that thrombolytic therapy, right? So in that thrombolytic therapy, we need to know when was the last time the patient was seen all okay, because there is a time limit on when we can give that TPA, right? So this patient is going down, this patient is going down. Now the next one, client C, The client with infective endocarditis is hemodynamically stable. Okay, at least we have one good patient here. Blood cultures are drawn, IV antibiotics started. The provider is planning to discharge the client with long-term IV antibiotics via PICC line. PICC line is peripherally inserted central venous catheter. So that's like, the patient will need long-term IV antibiotics, and we may have to arrange that with, we have to give discharge instructions to this patient and lots of multidisciplinary collaboration to happen. Okay, anyway, at least we know he's hemodynamically okay. This one, the last client, is going for that pacemaker. Now this one, they are doing a temporary transvenous pacemaker, because we would love to, this patient will need a permanent pacemaker where, like we discussed about the pacemaker in the cardiac session, where they have to subcutaneously, surgically, they will implant the pacemaker, and then the wire will be going into that SA node area or wherever it's needed. Depending on single chamber or double chamber, depending on that. So that's the permanent pacemaker. But right now, what is something we can do for now, until we get that permanent one down? They still need some pacing, because we know this was like hemodynamically unstable client, right? Our client D was going down. So what is something we can do right now? And that is temporary, and it's a transvenous. So they can use the jugular, or like veins here, and then they can put it, insert that pacemaker wire, and the lead can go into the heart area, and then, so it will be like a temporary fix, okay, until the permanent pacemaker comes. So the patient is getting that. Okay, so now we know what's going on with each one. This one is kind of okay. This one is going for temporary pacemaker. This is pulmonary edema. This guy is having a stroke probably. Okay. Now the question is, what actions are appropriate or not appropriate? And this is like a single, okay? You can either choose appropriate or not appropriate. So first one, administer nitroglycerin for client A. What would you say? Is this patient, the heart failure patient, the CHF patient, is the patient having MI? No, the patient is having pulmonary edema, right? So is nitroglycerin going to help in pulmonary edema? No, that's not going to be helpful. Actually, in fact, if that was a diuretic or some kind of, to get that things out, that would have been good. What else can we do for this client? Let's go back to this client. What else is something we would like to do? I would probably do a stat chest x-ray. That's one thing which can be done, because I want to know how much edema and things are going on. So that might be helpful. The other thing is diuretics. And of course, how about that? 84% on nasal cannula. What kind of, respiratory stuff should I be giving? Pulmonary edema, right? So I'm sure that I would probably go for a non-rebreather mask to make sure that they get, so something like NIPPV maybe. Like, we don't want to intubate the patient yet, but non-intubating kind of things, like, something which will be helpful for this patient, because this is not good. And with pulmonary edema, so that's not going to be okay. Okay, so that's what's going to happen, but not nitroglycerin, right? We need to get the fluid out. All right, so that's going to be not appropriate. How about obtain non-contrast CT of the head for client B? Is that appropriate? I would say yes. It is appropriate, because we think that he is having a stroke from the clinical description, but how do we know whether we can give that TPA or not? We need a CT scan. And when we are doing that CT scan to rule out the stroke, we go for the non-contrast one. And then, so we just want to know whether it's a hemorrhagic one or a ischemic one, so we can figure out whether we can give TPA or not. So definitely this is a good thing to do. So this I would say is yes. This is no. Okay, keep the client C in NPO status. That was our endocarditis patient. Does he need NPO? No, he was having decreased appetite. He is having infection. I would like him to eat something, right? So There is no need for NPO there. How about this? Continuously monitor client D for cardiac rhythm. Yes, this is the person who is going for a transvenous pacemaker. I definitely want to see everything on that patient all the time, right? So this is going to be yes, appropriate. Good job, good job. So this is going to be our taking action area. Okay, the step 5 where we are taking action, and you might get select all that apply questions, or it can be different formats. Okay, I just use this appropriate, not appropriate session. Okay, now we are coming to the end of the case study, which is the 6th step, which is evaluating outcome. This is where you might get questions on, is it improving? Is it declining? Is the patient needs something else? Or what's going on with the patient? Maybe you might get more tabs where it says the patient already discharged and now they're coming back for a follow-up, and you are seeing this, and it can be client teaching. So all those things can be incorporated here. This is what we have. Click to specify whether the clients are improving or declining. Client A, our CHF patient, now respiratory rate is 22, saturation is 94% on non-rebreather mark. Yes, it is improving, right? That patient is definitely improving. I'm so happy that whatever we did together for this patient, it worked. Okay, so he is improving. Okay, how about the second one, client B? Incomprehensible speech, paralysis of right arm and leg. Initially, it was slurred speech. Now, I cannot even figure out what he's saying. That's bad. Initially, it was weakness. Now, it's like paralysis. Okay, this is bad. Okay, that's declining. All right. The third one says, client C, WBC count within normal range, no fever. Okay, that's definitely improving. Good job. And client D, heart rate at 72 beats per minute. Okay, with pace rhythm, he was 38. Now it's like 72 and it's pacing. Okay, all good. Okay, that's great. Okay, good job. That's improving. So you have successfully completed an unfolding case study on multiple clients. How do you feel? Was it helpful? Was it helping you to think through it as if you are in the hospital taking care of these patients, right? Because that's exactly what NCLEX is going to ask you. So you can make this happen if you focus. That is for sure. And case studies are one easy way to get that done. We need to get our case studies above passing standard. Okay, the exam is divided into 2. Like one is going to be that case study stuff, the unfolding case study. Okay, you might also get case studies where it's like standalone case studies, which means there's a lot of information, but there is no unfolding. There is no 6 questions. When it is 6 questions, that's when we say it's unfolding. Take care.